Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Survival, Durable Tumor Remission, and Long-Term Safety in Patients with Advanced Melanoma Receiving Nivolumab by Suzanne Topalian et al. My name is James Gully, and I'm a medical oncologist specializing in cancer immunotherapy and serve as the chief of the genitourinary malignancies branch and director of the medical oncology service at the Center for Cancer Research, National Cancer Institute, National Institutes of Health in Bethesda, Maryland, USA. Decades of research suggesting an association between tumors and immune tolerance has led to the development of an array of immunotherapeutic strategies to reactivate the adoptive and innate immune system against tumor antigens. This understanding has led to the development of multiple immunotherapy approaches, including immune checkpoint inhibition. Emerging clinical data, such as those presented in this edition of the JCO by Topalian et al., introduces the possibility that not only can these immunotherapy treatments be added to treatment regimens, but perhaps they can raise survival curves to new heights. Identified in 1976, interleukin-2 was the first treatment to show promise in advanced melanoma. Although positive outcomes were limited, approximately 20% response rate with a complete response rate of up to 8%, these data were sufficient to approve the use of interleukin-2 in the malignant melanoma by the U.S. Food and Drug Administration in 1998. However, interleukin-2's substantial toxicity profile limited its application to select patient populations in specialized treatment centers. For the next 20 years, essentially palliative treatment options reported similar response rates without the durable complete responses seen with interleukin-2. Ipilimumab, whose trade name is Yervoy, is an anti-CTLA-4 monoclonal antibody and the first treatment to show improvement in overall survival in melanoma in randomized trials. Two separate, appropriately powered randomized controlled trials suggested a 28% to 34% decrease in mortality for patients receiving ipilimumab and a significant improvement in overall survival compared to the control arms. This landmark breakthrough for cancer immunotherapy led to Food and Drug Administration approval of ipilimumab for melanoma in 2011, but also brought a novel group of side effects presumed to be secondary to host immunologic enhancement. These treatment-emergent immune-related adverse events associated with inflammation of non-target tissues proved to be reversible by cessation of drug or with the addition of glucocorticoids. In this edition of JCO, Topalian et al. Report pooled outcomes for their expansion dose cohort of melanoma patients treated with nivolumab, another immune checkpoint antibody targeting PD-1. Patients had participated in the phase 1 trial of nivolumab in locally advanced solid malignancies published in 2012. The safety and outcome data cover a maximum follow-up of 4.3 years, the longest available for melanoma patients treated with an anti-PD-1 agent. Topalian et al. Included 107 patients from pooled cohorts where 62% had received at least 2 prior therapies, and included patients with ocular melanoma or clinically stable brain metastases. Patients receiving nivolumab were enrolled to a 3-dose escalation cohorts with dose escalation permitted within lower dose groups at disease progression. The author's analysis, based on findings of durable responses in this patient group, once again confirmed noteworthy survival outcomes. Median overall survival was 16.8 months, with 1 and 2 year survival rates of 62% and 43% respectively, and an estimated median response of 2 years duration in patients with confirmed tumor progression, which was 31%. Although the patient populations are different and the current published data for nivolumab are less complete than for ipilimumab, the overall survival signal seen is encouraging. Perhaps of greater interest is that the toxicity profile of nivolumab appears to compare favorably with the previous clinical experience with ipilimumab, although there are limitations to the comparison. In the first reported Phase 3 trial, Grade 3 and 4 immune-related adverse events occurred in 10 to 15% of patients treated with ipilimumab and included colitis and endocrinopathies. With a combination of ipilimumab plus dacarbazine, Grade 3 and 4 immune-related adverse events were seen in 38.1% of patients versus 4.4% of patients treated with placebo plus dacarbazine. Topalian et al. Reported that the most common adverse events of any grade was fatigue, 32%. Treatment-related select adverse events or immune-related adverse events of any grade were reported in 54% of the patients, most commonly skin disorders, 36%, gastrointestinal events, 18%, and endocrinopathies, 5%. Grade 3 to 4 treatment-related adverse events, however, were seen in only 5% of patients. The authors note that 17 patients discontinued therapy due to reasons other than disease progression, but do not specify if this is due to treatment toxicity. There were no drug-related deaths in the melanoma population, although there were a total of 3 episodes of grade 5 pneumonitis with this drug out of 306 patients, all in non-melanoma patients. It should be noted that with increased awareness of the unique immune-related adverse events seen with these immune checkpoint inhibitors, appropriate diagnosis and treatment may decrease the morbidity associated with this class of therapy. An intriguing common denominator in the studies of immune checkpoint inhibitors has been the number of durable complete responses or near complete responses. The ipilimumab trials show an apparent plateauing of the Kaplan-Meier overall survival curves after about 24 months, with 20% survival out to 4 or more years. Topalian et al. Also note this trend, reporting a flattening of the curve beyond the median for both progression-free survival and overall survival. This tail in the curve raises the questions about how to increase the number of patients who receive long-term clinical benefit from immune checkpoint inhibitor therapy and how to predict who those patients might be. One promising strategy, immunogenic intensification, combines one immune checkpoint inhibitor with a different immune checkpoint inhibitor or therapeutic vaccine. In one recent study, approximately half of the melanoma patients receiving the highest dose of ipilimumab, 3 milligrams per kilogram, and nivolumab, 1 milligram per kilogram, had dramatic and durable objective responses, though at the cost of an apparent increase in toxicity, with half of the patients having grade 3 or greater adverse events. Hypothetically, vaccine therapy could have a priming or steering effect on the immune system, potentially intensifying the effects of combination therapy. This could result in a more efficient tumor-directed immune response, potentially reducing the need for higher doses of immune checkpoint inhibitor or multiple immune checkpoint inhibitors and lessening the risk of inducing autoimmunity. Such approaches have the potential to improve clinical outcomes while minimizing side effects. As modern immunotherapy strategies such as nivolumab continue to demonstrate promising clinical outcomes, it may allow medical oncologists to raise their expectations for patients with metastatic cancer. Current treatment for metastatic solid tumors, apart from rare exceptions such as testicular cancer, remain palliative, but perhaps immune checkpoint inhibitors can be part of a strategy to enhance the number of patients who can enjoy sustained, durable responses. The data presented by Topalian et al. Suggests that nivolumab could have similar clinical benefits as ipilimumab, but with less toxicity. A limited side effect profile could be critical to deploying immunotherapy earlier in the adjuvant setting, perhaps in combination with antigen-specific vaccines. Initiating an ongoing, dynamic immune response with minimal tumor burden early in the disease course could allow a sustained anti-tumor immune response long after treatment is discontinued, perhaps magnifying the proportion of durable responses seen in the metastatic setting. If future clinical trials validate the findings seen in recent years, perhaps immunotherapy will not just raise expectations, but the all-important survival tale of the Kaplan-Meier curves as well. This concludes this JCO broadcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.